Data and Methodology. Part 1. Data Sources. The great majority of healthy aging indicators were derived from three primary data sources. First, the American Community Survey. This is a product of the U.S. Census Bureau, and it was the major source of demographic, socioeconomic status, and housing data for cities, towns, and also neighborhoods within Manchester and Nashua. The second primary data source was the Medicare Master Beneficiary Summary File. It's a product of the Centers for Medicare and Medicaid Services, and it was the major source of data on prevalence rates for chronic disease, disabling conditions, and Medicare service utilization rates. The third primary data source is the Behavioral Risk Factor Surveillance System. It's a product of the Centers for Disease Control and Prevention, and it was the major source of data for health risk behaviors, preventive health practices, and healthcare access. Other data sources. In addition to the three primary data sources, selected indicators were obtained from other data sources. This slide contains a listing of 7 of those other data sources. The American Community Survey. We downloaded data from for the American Community Survey from the U.S. Census Bureau Fact Finder website for all 259 individual cities and towns. In addition, we downloaded data for census tracts and zip code areas in order to create community profiles for sub-areas of Manchester and Nashua. The data we downloaded was the 5-year ACS data from 2012 to 2016. It's important to note here that the ACS data are estimates of counts of persons in either towns, census tracts, or zip codes. And all reported ACS indicators were either direct person counts or percentages derived from those counts. There were no statistical adjustments made to the ACS data. The Medicare Master Beneficiary Summary File. The MBSF is actually a set of 4 annual data files that are created by the Chronic Conditions Warehouse for CMS. These data files contain person-level summary records that are derived from Medicare claims data for all persons eligible for Medicare for at least 1 month during any calendar year. We obtained data for 2 years, 2014 and 2015, and the data for New Hampshire contain individual records for all persons who were aged 65 years or older on January 1st of either calendar year and had a state residence code of New Hampshire for either the 2 years. The 4 MBSF files contain the following. The ABD file contains Medicare program administrative data such as age, sex, monthly data on eligibility, whether there were Medicaid dual status or not, and whether they had Medicare Advantage enrollment. It also includes their date of death for any beneficiary who died in either of those 2 calendar years. The second file is called the Chronic Conditions segment. It includes prevalent chronic disease indicators that are derived from algorithms that are applied to the diagnostic codes on individual Medicare fee-for-service provider claims for 27 chronic conditions. The third file is called the Disabling Conditions file. It contains prevalence indicators derived from algorithms as well, from diagnostic codes, for 39 different chronic health, mental health, substance abuse, and other potential disabling conditions. The fourth file, called the Cost and Use file, includes summaries of annual service utilization and reimbursements for Medicare services, for services such as inpatient hospitalizations, physician visits, home health visits, skilled nursing facility stays, emergency room visits, and Part D prescriptions. A major strength of the MBSF data is that they contain records for 100% of persons 65 years or older with at least 1 month of Medicare eligibility and New Hampshire residents. 100% coverage allows us to estimate prevalence rate indicators for relatively small towns. A shortcoming of these data is that these indicators are derived from Medicare claims data and can only be measured for Medicare beneficiaries who receive their care from fee-for-service providers. For example, no indicators can be measured for Medicare Advantage enrollees because Medicare does not receive claims for these beneficiaries. Behavioral Risk Factor Surveillance System. We obtained respondent-level BRFSS data from the New Hampshire Department of Health and Human Services. These data contained information on the residence town and zip code of each respondent. This allowed us to estimate indicators for subareas within the state. A major strength of these BRFSS data is its rich information on individual health behaviors, including smoking, excessive drinking, obesity, and preventive health service use. There are two major shortcomings of the BRFSS. First of all, the survey design was developed for state-level estimates, not cities and towns. The sample size of respondents 60 years and older in any particular town is simply too small for estimating town-level rates. Second, the overall sample size of respondents 60 years or older in the state is small. It ranged from 2,867 in 2013 to 3,622 in 2015. Two steps were taken to increase estimation sample sizes for subareas of the state. First, we employed 3 years of BRFSS data. We pulled them together, for example, 2014 through 2016. Second, cities and towns were spatially aggregated together to form larger geographic areas. The end of part 1. Thank you.